All right. I'm Cameron Shirazi. I'm one of the spine fellows for this year, and I have the indications conference for herniated nucleus pulposus, HNP. So the outline of the presentation, a lot of just trying to find high yield articles and different recommendations. So in terms of why do we get herniated nucleus pulposus and why do we have pain from it, the workup, MRI, X-ray, physical exam, indications for different maneuvers and imaging modalities, and then surgery, when, how, why, options, and then ultimately results, and kind of looking at results and what needs to be done for these patients. We'll try to touch on the high yield thing. So cervical herniated nucleus pulposus, 3 different clinical presentations based on these 2 articles. In terms of what you would run across would be median kind of HNP, which would be myelopathy and central cord type symptoms. You can get paramedian, which would cause a Brown-Séquard, and then lateral, which would cause radiculopathy. Looking more in depth at radiculopathy, it's about 89 per 100,000 patients, and then 22% of those patients with radiculopathy present with or have HNP associated with that, based on that epidemiological study there, which was over the course of 14 years. Looking at lumbar HNP now, symptomatic herniated discs in 1 to 3% of adults per year, which is roughly 3.5 million herniations per year in the United States. Many lumbar herniations are asymptomatic or require no treatment. Specifically here, going over to a recommendations chart, which we'll get back to later in the chart. Looking at number 1, notes that they're fairly common. 1% of the general population is what their numbers had. And then focusing on 5, which we'll touch back on later in the presentation, surgical interventions will improve the short-term outcomes for patients with sciatica, but long-term studies show little difference between groups of patients treated surgically, patients treated conservatively, and we'll touch on why that is and how that is, and kind of touch on all these other bullet points as well as MRI and indications for surgical intervention, things like that. So just the pathoanatomy of why this happens and how it occurs. The intravertebral disc has the end plate, the annulus, and the nucleus pulposus. The annulus is mainly type 1 collagen, elastin radially, and with concentric lamellae rings. It gives you the tensile properties to contain the nucleus against compression. And then the nucleus pulposus itself, mainly type 2 collagen, high water concentration. It acts as a shock absorber, and then forces transfer to the annulus and adjacent vertebrae. With imaging there to kind of show you what we're looking at. When and how does HNP occur? The annulus gets disrupted. You get loss of resistance to the hoop stresses from the force of the nucleus, and then the annulus is allowed to escape, or the nucleus is allowed to escape via the annulus when intradiscal force is applied, and you get herniation of the pulposus. It requires typically a soft and pliable pulposus. Older degenerative disc, less likely to have herniations because of this. These are just some images showing how that can occur. Looking at biomechanics of this was a study looking at the lumbar disc herniations, vector of overload and instability. This was, or the part that I was looking at was the positions that would put you at risk for this, and what they noted from this study was lateral bending, flexion, and axial rotation. This was a cadaver study. And so just one facet of how this can occur. And then now focusing more on the low back pain and radicular symptoms, sciatica symptoms that come along with this. This is a prospective study, 193 patients undergoing lumbar surgery under local anesthetic. They stimulated different tissues to assess response and sensation. The normal, per the authors in this study, they quoted the normal nerve root was completely insensitive, but forceful retraction over an extended period of time resulted in mild paresthesias, but never any significant pain. And then sciatica could only be produced by stimulation of a swollen, stretched, or compressed nerve root. Other kind of facts they pointed out in the course of the studies that facet capsules rarely generate low back pain is what they noted. Synovium and cartilage surfaces were never tender, and back pain can be produced by stimulating several lumbar tissues. Most common is the outer layer of the annulus and then the PLL. Here's a rats study looking at more causes of why we get pain when we have a herniated nucleus pulposus. They looked at 3 groups: iatrogenic disc herniations, injected herniated nucleus pulposus, and then adipose tissue. In this, they studied animal response to stimuli procedure and disc herniations, and injected HNP groups were found to be hyperalgesic to noxious stimuli, but the adipose group had no change. So this study points to the fact that severe pain can be caused without a visually identified protrusion. Kind of delving deeper into this is a canine study looking at lumbar nerve roots that were clamped for 3 weeks and then assessed immunohistochemical staining, and they compared it to the contralateral nerve root, which was the control. Within this, mechanical compression of the nerve root leads to increased expression of inflammatory markers and cells. Those are listed specifically there. They're kind of the classic ones that we know about, and that just points to the fact that when you get this mechanical compression, it leads to this inflammatory response, and then that makes the nerve more sensitive to these different stimuli, as noted from some of these previous studies, and that's kind of the cascade and chain of pain there. Here's another rat study group, 4 groups. Within these, they were looking at role of HNP in the deformation of spinal nerve roots and dorsal root ganglion, and treatment of that. So they had 4 groups: a sham surgery, an iatrogenic HNP, mechanical displacement of the nerve root, and combined displacement and HNP. And they were looking at the threshold for thermal stimulation within the pause in this study, and the results showed mechanical displacement and exposure to HNP induced behavioral changes, but in isolation, mechanical displacement or HNP did not lead to behavioral changes. So another thing to look at when we're looking at the kind of anatomy, why this pain occurs, and give us a better understanding there. So the next kind of phase is workup, and what's recommended for the workup of this. What do you need to be doing for these patients when they show up to your clinic? So trying to look at some more evidence-based recommendations. So this is for physical exam maneuvers. Here are just 2, and we'll talk about studies related to these here in a second. But tests including shoulder abduction and Sperling's test may be considered in evaluating these patients for clinical signs and symptoms consistent with cervical radiculopathy, and that's a grade C recommendation for performing those maneuvers. Whereas manual muscle testing, sensory testing, and then straight and cross leg raise testing are useful in diagnosing lumbar disc herniations. This has a recommendation of A. So these are just look at, and then some studies kind of delving deeper into this and why this is important and what you should be testing in these patients is kind of the next few slides. So level of diagnosis of a lower lumbar disc herniation, and then so this is looking at sensation and motor testing. So 52 patients with lumbar HNP, that was noted not only on imaging but also confirmed at surgery. These patients were shown, they had 54% of them had sensory abnormalities, and 44% had motor weakness. And then the positive predictive value, I should say, of L5 sensory abnormalities for the L4-5 disc herniation is 76%, and S1 for L5 S1 herniations was 50%. And then positive predictive value paresis of dorsiflexion, so a foot drop for L4-5 disc herniation, 76%. And then kind of offshoot of that, per NASS guidelines, level 1 diagnostic evidence that sensory and motor testing can provide specific clues to the level of disc herniation. So this is just kind of showing the reasoning behind some of our physical exam maneuvers and what's necessary and what you should be looking for and how predictive it is of that. And you can see kind of the difference between 4-5 and 5-1 here, actually, which is surprising. Another study, in specifically what I was looking at here from this study was the straight leg raise, Lessig sign, and cross Lessig sign. So best sensitivity for symptomatic lumbar disc herniation is a straight leg raise, and it has about a sensitivity of 0.77 to 0.83. And then the best specificity is actually the cross straight leg raise, which is 0.74 to 0.89. So for their study, which also looked at some other things, they noted that all evaluated physical exam findings looked at within the study are beneficial and useful in diagnosis of lumbar herniated nucleus pulposus. So important factors when you're working with these patients and seeing them in clinic. And Here's another study looking at the seated straight leg raise versus the supine straight leg raise test in these patients. These are patients that were looked at prospectively. They had symptoms consistent with disc herniations, as well as confirmation on MRI. Here they found that the supine straight leg raise was found to have higher sensitivity than a seated straight leg raise, 0.67 versus 0.41 with a p-value of 0.003. So this leads to a recommendation, a B recommendation, or when you're looking at recommendations for physical exam maneuvers, the supine straight leg raise as compared with seated straight leg raise suggested for use in diagnostic lumbar disc herniation with radiculopathy with a grade B recommendation. Now we are going to switch over to imaging and what you should order, what's indicated, when it's indicated, and how it's useful in the workup of these patients. We'll start with the cervical spine. So this is a study looking at cervical neck pain or cervical radiculopathy, and when you should order x-rays. There's more factors and things they look at within it, but specifically this table here is new or increasing non-traumatic cervical radiculopathy with no red flags at initial imaging. So if one of these patients shows up to your clinic, MRI cervical spine without and with IV contrast, usually not appropriate. X-rays, which is kind of the question, is when these patients show up to your clinic, do you get X-rays? And that was the one that had some disagreement, and they just note that it may be appropriate. And then you jump to MRI cervical spine without IV contrast for new or increasing cervical radiculopathy is usually appropriate. We'll kind of talk up a little later on about when that should be ordered in the workup of these patients. Assessment of neck pain and its associated disorders. This was just a task force looking at neck pain, associated disorders, and when and where you should be ordering x-rays, MRIs, and there. So if you look here, so non-emergency studies, strong evidence for manual provocation testing, as we've noted previously, with physical exam maneuvers. And then looking here, if they don't have any red flag signs, weak or consistent evidence against MRI, and then weak or consistent evidence for range of motion, testing is being important in terms of physical exam maneuvers. And ultimately, when we are looking at cervical spine, I had difficulty finding any set of standards for actually when you should order x-rays and MRIs, other than the kind of the few recommendations we noted from these two papers. So a lot of them point to we should use rules that apply to the lumbar spine when we're deciding when to move forward with degenerative cervical pathology. So because of that, we will jump over to the or actually cervical spine, but we'll get back to the connection between those two when we get to the lumbar spine. More recommendations regarding the cervical spine. In the setting of a normal neurologic examination with acute cervical radiculopathy, you do not necessarily need x-rays on first visit. If the patient continues to be symptomatic over 6 weeks, even after conservative management, that's when you would obtain x-rays, is per this recommendation. And then the lateral radiograph is particularly helpful for helping more so than the AP is what they noted. Now, flexion extension views for these patients isn't necessary when they first show up to your clinic. This is a study looking at 258 consecutive non-trauma patients that had axial neck pain, radicular symptoms, or myopathic symptoms. These patients all obtained normal AP lateral as well as flexion extension views. 1% were found to have spondylolisthesis, noted only on flexion extension images, and 3% were dynamic. And out of these patients, that small percentage, no change in clinical management was necessary for any of these patients. Based on this, study, not a group-wide recognition, but leads to no longer regarding dynamic radiographs as useful for the initial imaging for patients with degenerative cervical conditions. This is not for surgical planning and things like that. This is just initial imaging that they make a comment on. So now we will jump over to lumbar indications for x-rays, MRI, and how to work that up. So just a few bullet points from here. I don't know if you can see my mouse, but uncomplicated and acute lower back pain and or radiculopathy are benign self-limiting conditions that do not warrant imaging immediately. The patients that you should get MRIs on are the ones that have the red flag symptoms or any worry for serious underlying conditions. And then in the absence of red flags, and we'll touch on this when we talk about imaging and treatments, is first-line treatment is conservative therapy. And then if you, once again, as noted kind of from the cervical spine section, if you have persistent or progressive symptoms during or after 6 weeks of conservative management, that's when potentially you want to move forward with the MRI. We'll talk about indications for x-rays here next. So this is looking preoperatively, what x-rays you should obtain. High quality AP and lateral are necessary for operative interventions such as discectomy, and so it's especially important, they note, for recognizing if there's an anomalous number of lumbar vertebrae, if you have any kind of transitional pathology or anything like that, because this will influence your intraoperative identification of the correct levels, and it can help detect other congenital anomalies, but it doesn't necessarily speak on how helpful it is in the workup. And as noted previously, it's not, unless they're having red flag symptoms, things like that, imaging is not necessarily required right away. Now, when comparing MRI versus MRI versus X-ray in the cervical spine itself, the clinical guideline recommendation here, if you have dermatomal arm pain alone and it's not specific in identifying the pathologic level in patients with cervical radiculopathy, so you need to have an MRI. So just because you have an X-ray showing some kind of osteophyte or something, and their physical exam might point towards a certain dermatomal level, they still, with a grade B recommendation, recommend getting an MRI. And then in the lumbar spine, there's the working group consensus here is in patients with a history of physical examination consistent with lumbar disc herniation with radiculopathy, MRI is recommended with a grade A recommendation for workup of this. And then here is their consensus statement that they note there readily that there's a paucity of high quality studies on advanced imaging patient lumbar disc herniations, but based on their group, that with history and physical exam findings consistent with lumbar disc herniation with radiculopathy, MRI is considered as the most appropriate testing that you should move forward in those patients, unless they cannot get an MRI, at which point a CT myelogram would be your best next option. So kind of summing up some of those recommendations: advanced imaging recommended for HNP regardless of location if considering surgery, and that would be MRI and CT scans. And then radiographs, low utility in x-rays in making the diagnosis, especially early on. MRI is the modality of choice. If considering surgery, static x-rays are appropriate to assess for instability in both lumbar and cervical spine, is what they know. Now I know that in practice that's a little bit different because different people looking at different parameters, but based on some of those recommendations I went through, that was what we had there. Now let's jump over to surgical indications. Absolute surgical indications is if you have a progressive neurologic deficit that is worsening, or you have cauda equina. Those are the two kind of set in stone ones, and there's a lot of other ones that we'll kind of try to go through and see when do you need to start considering surgery for these patients, when is it best, and when is it necessary. So in this study, this was a prognostic factors of symptomatic cervical disc herniation with radiculopathy. This was mainly looking at when the patient had this symptomatic cervical spine disc herniations with radiculopathy. They do recover typically without the use of any type of surgical intervention. So let's kind of delve deeper into this and look at some of specific studies looking at that. This is an older study, but kind of we'll march up the years as we go. But study outline for this study was 280 patients with lumbar HNP with radiculopathy. 87 were treated non-operatively, 67 were treated surgically because they, quote unquote, beyond a doubt required surgery, and 126 patients were randomized into groups. And findings within the randomized group showed that at 1 year, statistically significant, better results in the surgically treated group, but at 4 years and beyond, there was no difference. In their conclusions from the paper, pointed at surgical treatment is significantly better at 1 year. Over subsequent 9 years, benefits are less pronounced. The natural course of the radiculopathies is actually more encouraging than expected, and final examination after 10 years showed the importance of adequate teaching for these patients, because as we go on later, we'll talk about surgery versus non-op, but also so this is that same kind of article and recommendations we looked at earlier, but more specifically, some quotes and important factors pulled out from that. But over time, most patients with disc herniations recover with or without surgery, so that outcomes after 5 years are similar when surgical and non-surgical approaches are compared. In the end, the decision to operate on a patient with lumbar disc herniation should depend on patient preference. And they put rather than necessity, but it's important. That's a quote. Sorry, not quote at the beginning, but we'll kind of go into that and see when it's, there are times where it's necessary or indicated and can have better results for the patients. And then they also noted that the best surgical results occur when surgery is performed before 3 months have elapsed since the onset of symptoms. HNP in the cervical lumbar spine, typically self-limited process. Treatment can lead to similar endpoints as non-surgical. Surgery may shorten the duration of symptoms, but has associated risks. And then if you're considering surgery, some studies, as we'll get to here in a second, show that it might be beneficial to do within the first 3 months. So these are some more recommendations, working group statements. The first one is that over time, essentially disc herniations will often shrink, and that many but not all papers demonstrated a clinical improvement with decreased size of herniations. And so that shows that independent of treatment, the patients would get better, was kind of the summary of that statement. And then a second working group consensus statement is likely for most patients with cervical radiculopathy from degenerative disorders to be self-limited and resolve spontaneously over variable length as well. So looking into that and the treatment, when you should treat these patients and when not to. This is a cost utility analysis looking at 169 patients who underwent surgery for HNP. 52% of these patients underwent surgery less than 60 days from onset of symptoms. They showed greater improvement in their HRPQL scores, and they also gained higher quality adjusted life years. So this kind of points to the fact that you do get potentially better functional outcomes in those patients who undergo surgery. That previously we talked about the 3-month mark, but this paper noted that even within 2 months they get better results. And then, so when should you operate on these? This is looking at a literature review, bringing together the optimal duration of conservative management prior to cervical lumbar radiculopathies. And so all of these different papers they looked at, less than 60 days, less than 60 days, less than 60 days. This was less than 3 months. And then the last two didn't really give any times, but these point to the fact that their patients did seem to get better functional improvements and outcomes if they were treated within that first 2 months, maybe stretch it out to 3 months when you include this paper. So timing is important if you are considering surgery in terms of, maybe potential benefit for these patients. And so that's how you come to this is a Group B recommendation. This is a little broader recommendation, but it says that surgical intervention prior to 6 months is suggested in patients with lumbar disc herniations, as it has faster recovery and improved long-term outcomes. And those long-term outcomes we kind of just talked about. But this is a grade B recommendation, and it's also over 6 months. It's not as acute of a time frame as the studies we noted previously. Weakness is how important is weakness in terms of what results to expect. 56 patients with dorsiflexion weakness were looked at in this study, and to look at recovery, they measured dorsiflexion pre-op, 6 weeks and 1 year out, And essentially, what the results they come down to was that duration of the dorsiflexion weakness did not correlate with the recovery of dorsiflexion weakness. As you can see from these kind of this last section here, neither of those was statistically significant. And so outcomes in these patients, first looking at cervical radiculopathy, some data suggests that non-surgical treatment has inferior outcomes. 503 patients were looked at in this study, 246 with radiculopathy, 150 with follow-up data. One-third of the patients with follow-up data underwent surgical treatment. With medical treatment, non-surgical group reported slightly worsened ability to perform ADLs, but overall, both medical and surgical groups improved with treatment over time. Surgery group had better functional scores, patient satisfaction, 80 versus 60, and neurological outcomes, and better improvement when comparing pre and post-op pain. So this kind of is moving the kind of arrow towards potentially surgical treatment as being a good option for these patients. But let's look at all these treatments here that are non-operative treatments. This is looking at just medications and pain medications, NSAIDs, corticosteroids, antidepressants, anticonvulsants, and muscle relaxants, and opioids. Most of the pooled estimates did not favor the active treatment over placebo in these patients, and the efficacy and tolerability is unclear, is what they noted. And so for a specific kind of recommendation, systemic review of literature yielded no studies to adequately address the role of pharmacological treatment in the management of cervical radiculopathy from degenerative disorders. This is just another study, or like a offshoot of that. TNF inhibitors got a recommendation for not using them, and then gabapentin, IV steroids, 5-HT inhibitors, amitriptyline had insufficient evidence. So what are the NAS guidelines? They note insufficient evidence for cervical and lumbar herniated nucleus pulposus. Here's a study looking at the for physical therapy, on physical therapy. They insufficient evidence from their perspective. This study looked at 44 patients undergoing selective nerve root blocks, and then they randomized to the selective nerve root blocks plus or minus 4 weeks of PT. And they looked at, and the outcomes they looked at was low back pain, disability questionnaire, numeric pain rating. And their results and conclusions showed that PT does not seem to have a significant impact on the outcomes of their patients. Now let's look at epidural steroid injections for these patients. This is a large study because it looked at multiple cervical pathologies, including radiculopathy. And so we'll jump down just here for the radiculopathy patients alone, underwent conversion less commonly than stenosis patients. If the group that was more likely to undergo surgery was males, 35 to 54. And then the patients that got multiple injections, which potentially pointed to them getting benefits from these injections, were less likely to go to the OR, but the ones that only had a single injection, which likely pointed to them not getting a benefit, were more likely to go to the OR. And overall, even with epidural steroid injections, 20% of these patients still undergo surgery at 5 years. Here's one looking at transforaminal lumbar injections, and we'll just jump to the results. And it showed that the transforaminal epidural steroid injection plus local had better pain relief than any other treatment at 1 month. For these patients, this is comparing these here versus local alone, saline, IM steroids, or IM saline. Regardless of group, though, the percentage of patients who maintained relief diminished over time, which makes sense. And 36% of the patients who underwent these epidural steroid injections had undergone surgery by about 12 months. So insufficient evidence for transforaminal epidural steroid injections in the treatment of patients with lumbar disc herniations. A group A recommendation for short-term pain relief, though, in these patients with lumbar disc herniations, and then a grade C recommendation for the cervical epidural steroid injections. So in terms of highlights for non-operative treatment, many of the commonly used pharmacological treatments for HNP do not have strong evidence behind their use. Not a strong amount of evidence supporting the utility of physical therapy for either of these pathologies. Significant percentage of patients who get epidural steroid injections still undergo surgery, but it does help with acute pain, and then no definitive evidence that any of these non-surgical treatments alter the natural course of the disease or treatment. So outcomes for these patients, and we'll just, for the sake of time, kind of jump to conclusions on some of these papers, but this is a randomized control study looking at 81 patients that were split into 3 groups, ACDF, collar, and PT. So pain intensity, muscle weakness, and sensory loss can be expected to improve within a few months after surgery, and then slow improvement with conservative treatments and recurrent symptoms. And the surgery group make the 1-year results about equal. Surgical intervention is suggested for rapid relief of cervical radiculopathy when compared to medical or interventional treatments, but a grade C recommendation for single level degenerative radiculopathy to produce and maintain favorable long-term outcomes, kind of is what that points at. And here is outcome in these cervical patients, which paper we already kind of looked at earlier, but coming back to it. But 27% of surgical patients still describing worst pain as horrible, excruciating, even after surgery. 31% of surgical patients describe average pain to be distressing or discomforting. 80% of surgical patients that were satisfied or very satisfied, and 60% of non-surgical patients. And overall, non-surgical patients have slight worsening of ADL functionality over time. Sport trial is what we're looking at here, and specifically this was 743 patients with at least 6 weeks of symptoms. 528 were treated with open discectomy, 129 were treated non-operatively. Results here is that patients with a persistent sciatica after non-operative treatment for 6 weeks improved on both surgical and non-surgical groups. No matter what treatment, things were likely to improve. But surgery group doing better at all time points, but it becomes narrowed at 2 years. Here's another long-term study, 400 of the 507 initial patients, follow-up questionnaires. They looked at back pain, functional status, and patient satisfaction at 10 years after surgery. 69% of surgical patients versus 61 of non-surgical patients reported improvement in their leg and back pain symptoms, and then 71% of surgical patients versus 56% of non-surgical patients were satisfied with their current status. Overall conclusion is that patients still have significant disability at 10-year time point regardless of treatment. So it is important to, as noted earlier from the recommendations, to educate your patients on these facts and let them know kind of what the long-term consequences are. And so grade B recommendation for surgical decompression to better medium-term symptom relief compared to medical interventions, and then surgical decompression provides long-term, greater than 4 years symptoms relief for patients with radiculopathy from lumbar disc herniations whose symptoms warrant surgery. It should be noted, though, that, like we noted earlier, that a quarter of those patients still have chronic back pain or leg pain, and so it's important to educate your patients when you're talking about indications and kind of what expectations to have after surgery. Summary of some of the kind of indications for acute cases. HNP is typically self-resolving, as was shown, kind of going through all those studies. List of absolute surgical indications is actually rather limited, kind of with those two, cauda equina versus worsening neurologic decline were the two main ones that were absolute surgical indications. Relative indications for surgery, there's a lot of those, and patient preference should play a role in that, and that's why patient education is important, so they understand why and which treatment plan to pick if symptoms fail to resolve within 6 weeks. Surgery can offer comparable long-term outcomes to non-surgical treatment. Data suggests that surgery may decrease short-term disability compared to non-op, but you have to take into account the risks of surgery that are associated with that, which is its own thing. And then if you do choose surgery, some data suggests better outcomes with earlier treatment, just for, in a broader sense, 2 to 6 months after onset of symptoms, but it seems like most of the papers point to more 2 to 3 months for their recommendations for that. And then no matter what you choose, as kind of stated throughout this, you need to set expectations that there's a good chance you may have persistent pain and disability, which could persist over time. It's not a kind of hole-in-one or anything like that. And so you just have to reason with your patients and make sure your indications, as we've gone through, and whether it's physical exam and imaging, are all clear, and make the right decision. Sorry, there's a lot of stuff. Try to summarize it down and pick some high-yield papers and recommendations.
Big topic.
Yeah.
Great job, though, and those
those guidelines are there for us to understand and know, based on the literature that's available. I helped write the surgical ones, and like it is a ton of work that goes into this, and grading all the papers and trying to find the right ones to make, objective decisions off of. But it's some of these guidelines are actually pretty good. Just a couple comments. One is that we we can take pressure off nerves, but if a nerve has some inherent injury to it, then even removing the noxious stimulus is not necessarily going to change the fact that that nerve was damaged, right? And I use that word loosely, but sometimes you see persistent radiculopathy, or you see, persistent pain, even in the absence of, like, when you get a repeat MRI, of there being really no compression left on the nerve, or having done a good job with the discectomy. So just realize there are going to be some patients that, especially ones that have like these violent large herniations, that are just going to maybe not do as well. So that's one thing I do counsel patients about. And the other thing I just wanted to make comment, I'll just kind of emphasize what you said right there at the end, Cameron, which is, I think we have a tendency to think that disc herniation surgery is kind of like a slam dunk, but it's not. Like it's basically 1 in 4 have issues in the long run, right? So it's actually a decent number of patients. I herniated my disc at 5'1", and it took me about 2 or 2.5 years before, like, I was back to just about my normal self. For whatever reason, like, things take a long time, and that's not everybody, but certainly, at least from what I've seen, is not necessarily abnormal either. So a lot of hand holding, encouraging, let them know that, we took pressure off nerves and gave it a better environment for them to heal.
And hey, Greg, how long did you suffer before surgery? I can't remember. It was a while. Miserable.
So I herniated at SRS. So that was September, and then we cut it out in January.
Yeah, so it's a while that you struggled, huh?
Yeah. Well, the epidural worked for like 6 weeks, and then it came back with a vengeance. I was like, screw this.
Hey, Cameron, looking through those studies, what do you think the most updated quote for herniation rate would be? Just making sure I'm still giving them the best sort of quotes to my patients. Did you come across that at all?
I'd have to look back. I'm sure I have a bunch of like the papers pulled. I bet you I could go back and actually find one.
What do you guys say,
that question,
Bob, Greg, Jamie, whoever? What rate of recurrence do you quote, folks?
I say 10 to 15%. 10 to 15%.
Yeah.
It's a little bit higher by MRI. It's upwards of around 15 to 25% that you'll actually see some imaging-based recurrence, but clinical recurrence is around 10 to 15.
Yeah, I use 15. I always go high.
Yeah. Yeah, I was saying 10. I think that extra 5% will give me a little more latitude.
Yeah, exactly.
I think patients work better on 10s than those increments.
Maybe I'll just go 20. Really, said to them,
like 90-10 versus 85-15. I think people just, I don't know.
And for you guys that are going to be starting your own practices first, like the first year I was in practice, I was like 10%. None of my patients have recurrent disc herniations. I pull on it just the right amount. And then like year 2 started, and then like, people started coming back with this recurrent herniations. I was like, oh, I see. You just have to be in practice for more than a year.
So true.
Good job, Cameron.
Yeah, big topic.
Thank you.
The ones I always struggle with are like when they show up at your office at, 2 months and 20 days, and they haven't really had much treatment, but they're pretty miserable, right? What do you do with them, right? Do you inject them and make them feel good for 2 months? And now you're all of a sudden at like almost like the 5-month mark, and you know that, these herniations do best treated early, and I don't know. Like, those are always the groups. Or the other one I think you didn't. I'm not sure if you mentioned or not is the painless weakness. You know, where they have like a 4 to 5 Tibant and they have absolutely no pain. You know, I've had a few that had like florid foot drop without pain. Like, what do you do for them? You know, so
I usually let them
those are always
cry, you know,
those are always the
if
fun
their
ones to
pain's
discuss.
responding.
Yeah.
Unless it's
Agreed.
gotten worse. Weakness.
Yeah, monitor is usually what I say, so it doesn't progress. Cool. All
Excellent.
right,
Well, have
guys.
a good day, everybody.
Awesome.